Hello, my name is Jeff Goldhagen. I'm a professor of pediatrics at the University of Florida and have the privilege and pleasure of being the president of the International Society for Social Pediatrics and Child Health. I follow a close friend and colleague of you all, Nick Spencer, and it's been a wonderful opportunity to follow him and follow in his footsteps. Today, I've been asked by you all, and I appreciate the opportunity, to talk a bit about translating the practice of pediatrics into a child rights-based approach. So I'm going to share my screen and move on from here, hopefully. And yes, so what we're going to talk about today is actually moving from the concept of disparity to equity in the context of building a rights and equity-based approach to child health and well-being. And the primary question for us all is, what is the relevance of the current practice of pediatrics and the work of pediatricians to actually the health and well-being of children? That's a fundamental question that we need to ask ourselves. And in particular, over the last 10, 15, 20 years, it's become really very clear that health care, as we practiced it over the decades, contributes only a small amount, 15 to 20%, to health outcomes, with the social determinants of health being the primary generators of health with children. And so in that context, then how does the traditional practice of biomedical medicine relate to the outcomes that we all seek for our children? We take a look at the root causes of child health today, at the global level as well as on the local level. We're dealing with issues related to globalization, the existential issues related to climate change, and this is critically important at this moment as COP27 is completed. And if we look at the breadth of issues that we're dealing with in the world today and in our own communities, issues like war and violence, migration and refugees, which has impacted Europe and the UK along with the rest of the world, poverty, malnutrition, emerging infections, in particular related to the coronavirus that we're experiencing today, and the environment beyond just climate change, but a host of issues related to environmental impact on the health and well-being of children. So these are really the root causes of the issues that we're dealing with today, many of which have not been relevant and to a great extent to a biomedical approach to the health and well-being of children. If we look at issues on our national levels, whether it's in Europe or Britain or the US, we have issues related to racism, be it personal, structural, and institutional racism, discrimination based on class, gender, and sexual orientation, issues related to immigration, ethnicity, and the geography, the context of the built environment and where we live, in particular in our own countries, civil, political, economic, cultural, and the physical environments that children grow up in. What we've learned over the past 10, 15, 20 years related to early brain development and its impact along the life course, access to medical services, in particular for vulnerable children, and again, the built environment. And these complicate the global issues that we just spoke about, issues related to climate change, globalization, and so on. So these become the primary issues that are confronting us as pediatricians. And the question is, how do we use our traditional approaches to address these issues, or do we need a new paradigm in order to address them? And there's an historical context to this. We think in terms of perhaps pediatrics being a static practice. We are here where we are today, but in fact, there's been a history related to this. This is a complicated slide. but one that I think provides us some context for where we've been. And, the old saying is, if you don't know where you've been, you really can't determine where you're going to be going. So this relates more particularly to the US, but I suspect it's relevant also to those of you practicing in the UK and elsewhere. So in the 50s, we had really the beginning of what I would suggest is general pediatrics. I pick the 50s because that's really the introduction of antibiotics and immunizations. Then in 20-year intervals, we've moved from a focus on infectious disease and nutrition to one focused on psychosocial pediatrics, the role of the family. We began to see the development of behavior and development in adolescent health become primary considerations in the practice of pediatrics, then moved to the community where we began to focus on the environment and mental health and school health and the impact of drugs, STDs, alcohol, and so on and so forth on children. And then around the year 2000, we began to talk about the Millennial Development Goals and millennial pediatrics, and began to understand the impact of globalization on pediatrics. And there, at that point in time, we began to talk about the social determinants of health, including economic, political, civil, and environmental issues. So this has been it's been a journey. It's been a journey over the last 50 to 70 years that has brought us to a point where we begun to understand that issues related to globalization and climate change and society are the fundamental determinants of children's health, and not those that were fundamental back in the 50s, where we focused on immunizations and antibiotics and infectious disease and nutrition. If we look at the epidemiology of this journey, we started really back again in the 50s, focused on infectious disease and nutrition and diarrheal diseases and so on and so forth. Not to say those aren't particularly germane now in low and middle income countries, and with the environmental impact of climate change becoming increasingly important. But in fact, those are traditional epidemiology in high-income countries, not ones that we're necessarily dealing with as a priority. But over the years, starting, and we'll talk more about it, with the work of Sir Michael Marmot in the UK, began to really understand the impact of social epidemiology and the social determinants of health. And those have then provided us the main focus over the past 30 to 40 years. And then augmented by our understanding of the life course sciences, epigenetics, and so on and so forth. We'll talk about that in a moment, but it's critically important to understand that we've been on a journey here, simplified in this slide, starting with general pediatrics in the 50s, going into the 70s, into the psychosocial pediatrics, moving in the 90s to community pediatrics, and now really focused now on social and societal pediatrics, where we now understand the importance of the social and environmental determinants of health. So for this model, this new paradigm for the practice of pediatrics, it's the intersection between biology, the social determinants of health, and the environmental determinants of health. And in that intersection, we're talking about the practice of community and social pediatrics. So the challenge we have now is really to translate what we know into practice. We can start off again with what we know about social epidemiology, beginning with the Whitehall studies and understanding the impact of the social gradient. Subsequently, we had the ACE studies in the US, which showed us and demonstrated there's a pyramid that is grounded in the context of the adverse experiences of children that results ultimately in early death as those adverse experiences accumulate. Those ACE study associations included alcoholism, chronic obstructive pulmonary disease, mental health issues, behavioral issues, smoking, suicide, and so on and so forth. So what we've come to understand is that, in fact, adverse childhood experiences have an impact across the life course. We've learned a lot about income inequality and income inequity, such that it's not just about poverty, but that the distribution of wealth in countries has a significant impact on ultimate outcomes for adults as well as children. And the more inequitable a society is, regardless of their GNP, the worse the health outcomes are. In the US, we had some interesting studies actually published initially by a friend and colleague of mine that demonstrated that African-born Black that emigrate into this country, their birth outcomes are actually far better than US-born African Americans, and actually parallel those of white Americans. Ultimately, through an iterative process of trying to understand that, it became really very clear that this was the impact of racism. If you take a look at the educational status of infant mortality based on the educational status, you can see here that, in fact, African Americans who have 16 plus years of schooling, their infant mortality is far worse than white Americans with less than 9 years of education. Again, demonstrating the impact of racism on individuals. If you take a look at the impact of place on health, and we've heard a lot about the built environment and also about racism, and it matters where you're born, whether it's within a country or within a state or within a municipality. We say here that zip code really determines health outcomes, and you can see that the South is a very dangerous place for women as far as life expectancy is concerned. And I suspect that you could draw the same demographic maps in the UK. So our next challenge then is to translate what we know into practice related to science. And the social epidemiology unfolded over the last several decades, but it's only been within the last 10 to 20 years where we've begun to understand the science that underlies the epidemiology. We've learned a lot about how maternal stress crosses the placenta and the impact of stress on cortisol and the adrenal axis, so to speak. And so that's been of critical importance, in particular as it relates to our understanding about the impact of racism and discrimination on health and birth outcomes. This is an example of the disparities in stress and CRH in pregnancy related to those babies that are born preterm versus those that are born full term. We know that there's pre-programming of childhood obesity, and that by the time a child is born, their propensity to be obese has already been defined. And of course, we know now about the impact of epigenetics, that it's not so much the genes that we inherit as much as it is the environment in which those genes are expressed. So much of what is being published now is about epigenetics, and not so much about genetics, because again, the impact of the environment is a critical factor on the expression of genes and who we are as children and who we become as adults. So given those challenges and our understanding of the impact of social environmental determinants of health, we published a piece in Pediatrics almost 15 years ago now, 13, 14, 15 years ago now, that discussed how to move the practice of pediatrics into one that's that is based on, grounded in health equity and child rights. And in that paper, we suggested that there are 4 domains that we need to pay attention to, in which this paradigm change is occurring. The first is child rights. The second is a concept of human capital investment. The next is social justice, and the final is health equity ethics. And we'll be talking about these as we progress here. So with respect to child rights, we all know about the Convention on the Rights of the Child. It came into force in 1989 and has around 40 or so substantive rights that really define the necessities, the needs for children as it relates to optimizing their health and well-being. It defines a child rights-based approach, suggests that every child is entitled to the best possible health and access to health services. With respect to our domain, Article 6, which we'll talk about in a moment, reflects on the right of every child to life and optimal survival and development. And it puts an obligation on states and individuals and us as duty bearers to ensure that those rights are fulfilled, and that there are actions to ensure children enjoy, in our particular case, the right to health, and so on. So with children being rights owners, and us in particular as professionals being duty bearers, we have a critical role and responsibility to fulfill the rights of children in our context to health and well-being. Within a child rights-based approach, or within the principles of child rights, there are 4 critical elements. The first is non-discrimination, which is Article 2 of the Convention. The next is best interest, which is Article 3, optimal survival and development, which is Article 6, and Article 12, which speaks to providing every child a voice and to be listened to. So these are the primary articles of the convention on which all the other articles are based. So there are 3 primary concepts within a child rights-based approach. The first is that the rights of children are inalienable. And the second is that they're universal. And that's critically important for us in today's world, in particular, as we see children on the move, moving across borders, that in fact, their rights adhere to them wherever they go. And that it is critically important that wherever they happen to be, in whatever context, that their rights are fulfilled in the same way that the rights of children who are citizen in countries, as an example, are fulfilled. So as children are displaced within the countries, as children are displaced across borders, that their rights are inalienable and universal and adhere to them. The next concept is that all rights are indivisible and interdependent. And although we have these 4 primary rights, that you cannot fulfill one right in the convention, amongst the articles of the convention, without fulfilling all of them. And so as we look at the rights to health, it's not just Article 24 that we need to focus on. It's all of the substantive rights in the convention. We'll talk about that in a moment. And so there are multiple ways of dividing up the substantive rights within the articles of the convention. One way is to look at economic rights, cultural rights, social, protective, and civil and political rights. And so these become our role and function as duty bearers to fulfill these rights and to think in terms of what are the economic rights, what are cultural, social, and so on rights. So this guy takes our role and responsibility far beyond a biomedical approach to really look at these core rights as they relate to the social and environmental determinants of health. And as you can see on this slide, In fact, whether we're looking at poverty or income inequality, or discrimination, racism, or what some people refer to as childism, which is discrimination against children, we can look at how each of these social determinants and others relate to specific domains of rights and the specific articles within the convention themselves. So this becomes a tool for us to be able to use and conceptualize how we bridge the chasm between understanding the social determinants of health and how they actually relate to the specific articles of the convention. Another way of looking at it, if our role as pediatricians is to advance the social, physical, emotional, and mental well-being, mental health well-being of children, then within the context of social well-being, we have a distribution of rights, as you can see here on this slide. And so on and so forth with physical well-being, emotional, and mental well-being. So our role, if in fact it is to advance these types of well-being or to ensure a holistic approach to well-being for children, then is to address these particular rights in our work. We want to take a look particularly at the convention and the right to health. You can see there are a number of parameters that are included in that right. But then, as I mentioned, you can't fulfill the right of children to optimal health and well-being if you don't address the other related rights. And in particular, those identified here. And although all of the rights relate to fulfilling the right of children to health, these are examples of particularly relevant rights. And identity, access to information, privacy, issues related to children who are adopted, refugee children, children with disabilities, as an example in Article 23, but also in a related convention on the rights of people with disabilities that came into force just after, as the next convention after the Convention of the Rights of the Child, and even issues related to, as an example, Article 37, which relates to deprivation of liberty, issues related to children and youth in juvenile justice systems, those are in care, and so on and so forth. So these are the related rights that we as pediatricians need to be focused on, in addition to the very specific right related to health, which is Article 24. If we move on, and we'll come back to this in a moment, if we move on to understanding the concept of human capital investment, what it says is that we can, as pediatrician, relate and focus on 5 different areas related to investing in human capital of children. One is social relationships that positively influence the health and well-being of children. Economic domain, which relates to ensuring that children and families have the monetary resources available to ensure a basic standard of living. Environmental, not only the physical environment related to where children grow up and their exposure to toxins, but also the psychosocial space within the family and within the community in which they grow and develop. Educational capital, and personal capital. And by personal capital, we mean investment in the dignity and identity in children and giving them hope. If they grow up without dignity and without respect and without a future perspective and without a hope for a future, then we can do little to actually optimize their health and well-being. And if you take each of those domains, right, each of those forms of capital investment, personal, educational, environmental, social, and economic capital, you can see that, in fact, each of those bullet points relates to a particular article within the convention. So taking all of the articles, the 40 substantive rights, and dividing them into these 5 forms of human capital investment gives us a framework that we can use in a very efficient and effective way, so that when we approach families, regardless of the environment in which we approach them, from a subspecialist perspective or a community pediatrician's perspective, if we focus on these 5 forms of capital investment and look at the articles of the convention that relate to them, we now have a framework that we can use to translate the convention actually into a form of practice that's efficient and effective. The last one we're going to talk about today, we're not going to talk about social justice, but just briefly introduce the idea of health equity ethics. If we take a look at the taxonomy of rights, which we looked at before, the inventory of rights, which you see in the center, and if you look at the principles of biomedical ethics as it relates to children, justice, autonomy, beneficence, and non-maleficence, each of these principles of ethics can be related specifically back to the inventory of rights and to a taxonomy of rights. So we have a way of translating the principles and practice of child rights into the context of biomedical ethics as it relates to children. And so that translation then gives us a foundation for ethics actually in rights. So let's talk briefly about translational tools and a framework and how we actually move these general principles actually into practice. The first is that we need to relook at what our role and responsibilities are. That we are certainly child health professionals trained in the science of medicine for sure, but ultimately what we are child advocates. Child advocates, I would suggest, that base our advocacy on a child rights-based approach. And that certainly we are experts and professionals functioning at the clinical level, but unless we also function at the community and systems level and at the public policy level in the context of our child advocacy, we'll never be able to accomplish the outcomes that we all seek for children. The second is to, as the role of a child advocate, our role is to translate the social epidemiology and science into practice. And as you can see here from this slide, that practice ultimately is a health equity practice, one that is grounded in child rights and social justice and human capital investment and health equity ethics. And in order to make that translation, what we need is a set of health equity tools, which in fact exist. The next is as we move along this continuum, is to understand that there's a logarithmic change when we move from understanding children's needs and use the parlance and understand that these, in fact, are not just needs, but they are rights. And so if you want to divide this up, you can divide it up however you want. But here we see a slide that shows that the children have physical needs, social, economic, and cultural needs, and intellectual, psychological, and emotional needs. Again, you can define these needs however you want, but if you look at these needs, right, if you look at these needs, then you can identify specific articles of the convention that relate to each one of these needs. So that it's critically important that we move from understanding needs to reframing them as rights. Because needs, to a certain extent, we've done a great job in the past of ignoring many children's needs, but we can't, in theory and in the future, in practice, ignore the rights of children. And as you can see here, again, these are a way of reframing those rights in the context of these different areas, domains of child rights. The other way of doing that is really to think in terms of promotion, protection, and participation rights. So promotion rights are the basic rights to life, survival, and development. Protection rights are keeping children safe from harm, and participation rights are ensuring that they have an active voice and role in their community. And again, if you have the time to come back and take a look at these slides, you can see that we can take all of the articles of the convention and divide them into promotion, protection, and participation rights. And again, that provides us an effective and efficient way to think about children, to think about how we practice pediatrics, and then our role as child advocates is to advance and optimize promotion, protection, and participation rights of children in a similar way that we can think in terms of advancing their economic, cultural, social, protective, and civil political rights. So there are multiple ways of taking these 40 substantive rights and dividing them up, and to give us tools to be able to use them in practice. And I'm not going to go through this slide, but what it's meant to do is to suggest that there are multiple translational tools that are currently being used that are rights-based. There are foundational tools, diagnostic and planning tools, and interventional tools that provide us a mechanism and capacity to translate needs into rights, and then rights into practice. So the next part of the presentation, and I know that I'm going fast, but this presentation is not meant to get into depth, but just to give an overview of how far we've come and our capacity now to move from a biomedical approach to practice of pediatrics and to a rights-based approach. So another tool that we have, in addition to the Convention on the Rights of the Child and the Convention on the Rights of People with Disabilities, is the Sustainable Development Goals. And for those of you who remember, we started off in the year 2000 with the Millennial Development Goals that were to last to 2015. Actually, the world made great progress on those Millennial Development Goals. And then in 2015, the Sustainable Development Goals were launched. And as you can see, we went from eight Millennial Development Goals to 17 Sustainable Development Goals. If you take a look at those Sustainable Development Goals, the SDGs, they all relate in general to children, but a number of them relate specifically to children. And so the SDGs really are a complement to the UNCRC. And if you want to translate, and there's a way of translating these SDGs into an agenda for social pediatrics. This is a proposed agenda. It's not written in stone. It's a way of thinking about the translation of those SDGs into the critical root causes of children's health and well-being. And as pediatricians, we need to think about addressing the lack of secure places for children, countering the impact of poverty, mitigating discrimination and social exclusion, minimizing the effects of social and environmental determinants of health, in particular climate change, responding to increasing medical complexity, respond to changing structure for families, counteracting the effect of marketing and consumer societies, intervening in the consequences of globalization, and thinking of all policy as child health policy. So this provides us an agenda for moving into the future using the SDGs and a foundation of child rights and the UNCRC as the framework for this movement. And if we take each of those elements of this agenda, we can apply the SDGs and specific rights to each of these elements of a framework an agenda for social and societal pediatrics. And again, we don't have time to go over each of those agenda items, but this presentation will be available. And if you have the time and inclination, you can go through this and really look at what the definition is of each of these elements. And this work actually is included in the ISSUP website as a policy statement. And you can go through that. It's in more detail than we have the time to talk about today. But it does begin to provide us an agenda and a framework and a blueprint for how we begin to move from a traditional biomedical approach to really looking at a rights and equity-based approach to child health. And so the next steps for us, specific next steps for us, and again, I'm not going to go through these, but we'll leave these to you to peruse on your own time as part of this presentation. But there are very specific steps that we need to consider and take. These aren't written in stone, and there are certainly others that we can look at and add, but these are specific steps that we need to think in terms of as we move from a traditional approach to pediatrics into a rights and equity-based approach, starting off with embracing the World Health Organization definition of health. Now, these steps are not in chronological order, but I would urge you to look at them and begin a dialogue and discussion within BACCH and within the Royal College and other venues to look at how we move forward, again, with developing and implementing a rights and equity-based approach to child health. So where we are today is really at a junction of moving from the past into the future. The critical issues impacting children have changed. The root causes of children's health and well-being have changed. There's never been a time, certainly in my career, where the assault on children has been so fundamental, whether it's globalization, whether it's climate change, whether it's migration, the impact of armed conflict on children, commercialization, and so on. These are the global issues that we need to address in pediatrics, not just and child health, with child health professionals beyond pediatricians, not just at the global level, but also at the local level as well. And so I want to thank you for the opportunity to be able to talk with you today. We look forward as an organization to work with BACCH as you move into the future and as we move into the future. We encourage all of you to go online, look at our website, which is now being reconstructed. We urge you to join ISSUP. We've moved to a donor-based opportunity for membership so that there's no set amount. We ask you to join far beyond your monetary contributions. We're far more interested in your passion and your knowledge and your expertise and your commitment as we move forward together. So I want to thank you for the opportunity to talk. We look forward to the partnership that we've developed with you all. Together, our voices are far stronger than they can be as individuals. And I leave you with one final peaceful look at our beach here where I live in Ponte Vedra, which because of climate change almost doesn't exist at this point in time. After the last two hurricanes of Ian and Nicole, we've almost completely lost our beach. And it talks specifically then about the personal issues that we are addressing every day. So thank you very much. And we look forward, as ISSUP, and I look forward personally to work with you in the future. Thank you.